Well, good day, everybody. This is Chris, the Ancient Scholar. I hope this video finds you all doing well. So in this particular video, I'm actually going to be talking about something medically relevant. I know it's been a while. All apologies. So in this particular video, what I'd like to do is I'd like to talk about ventricular tachycardia. And the reason I'm doing this little discussion is I'm now seeing, just started a new cohort of paramedic students, and one of the courses that we teach pretty early on, so we have some prerequisite work that we do with the students, a lot of like operational advanced assessment techniques, medical, legal, the typical stuff, and then we do a block of instruction on chemistry and pathophysiology and growth and development, and of course pharmacology, and we kind of front load all that. But then the first actual course in the pipeline of the paramedic program that our students encountered in their first semester is ECG interpretation. And that's when they start learning the nuances of electrocardiology and just how complex it really can be. And one of the interesting discussions that always comes up is in the more advanced or nuanced differentiation of cardiac rhythms, of wide, complex tachycardias. And one of the things that you can see, not just with students, with just kind of out in the internet in particular, videos, discussion boards, things of that nature, are these very vociferous discussions and arguments around attempting to differentiate a ventricular tachycardia from a supraventricular tachycardia with aberrancy. So essentially, how is this rhythm a true quote-unquote VTach, or is this rhythm that I'm seeing a supraventricular tachycardia, and there's bundle branch block or some intraventricular conduction delay that's making it look like VTach? And what are all the little tricks and tips and things that I can use to really dig deeply into the 12-lead ECG and attempt to make that differentiation? As an intellectual exercise, I think it's interesting and it's compelling to think about these differentiations, and you're looking for AV dissociation, and are there dissociated P waves somewhere in there, and okay, let's figure out the axis. Okay, there's right shoulder axis deviation that suggests this is more VTach. There are all these tools you can bring to bear, and it makes for great, how should I say this? I'm going to be a bit crude, but it makes for great intellectual masturbation. No doubt about that. In this video, what I want to argue is about clinical relevance, taking intellectual masturbation and applying it in a real world situation. These are two very, very different milieu. And perhaps I'm thinking about this in part because I've just spent the last 3 months in the hospital, taking care of patients, working with paramedic students, and encountering real world scenarios involving emergencies. And we've done some cardioversions and some defibrillations, and we've had some codes, and we even had a really interesting situation involving Wolff Parkinson's White with AFib, and I think this is the first time I've administered this drug in years, I would have to say. I can't even remember the last time we administered this medication. We administered a kind of an esoteric sodium channel blocking agent to treat this very specific type of manifestation of Wolff Parkinson's White disease, of the AFib that was causing SVT. Procainamide is a medication. So that kind of stuff is happening, but it got me thinking, what you have the ECG, you have your patient presentation, and you're in the back of an ambulance, or you're in somebody's home, or you're taking care of somebody who's had a syncopal episode in the frozen food aisle in the grocery store, and you are encountering this situation where a lot of things are happening in the scene with a patient, and you have to make fairly substantial decisions in a very short, compressed time frame. And I think that's where I kind of take issue with some of this over-intellectualization of ECG interpretation that can happen. And look, I'm guilty of it, right? You can see some of my ECG videos where I go deep into OMI, and I'm still in that cult. But we also have to recognize that where do we draw that line, and how do we address over-intellectualization? Some people would refer to this as analysis paralysis. Like when you actually are encountering a patient in an actual real-world scenario, you don't have time to go to your computer, go to your phone, and have a multi-day discussion with some dude living in his mother's basement, right? Some 40-year-old dude living in his mother's basement, right? And you're going back and forth, and you're having this in detailed argument over hours, days, weeks, months. You just don't have that in an actual patient encounter, and you have to make decisions about patient care. And there is a very big delta between the intellectual and the practical application of some of this stuff. And so that's kind of where I want to, the main thrust or the main valence of this particular video is with that concept in mind. And so what I would suggest is, by and large, if you are encountering a patient, particularly a patient that has any component of instability, right? Hypotension, ischemic chest pain, acute altered mental status, right? Signs and symptoms of shock, new onset or presumably new onset pulmonary edema, these sorts of things. They look like they're really sick, in other words. So you have a patient that looks like they're really sick, and they present with a wide, complex tachycardic rhythm. You may not have the time to have this overly intellectual discussion at the point of patient contact about, well, maybe we can suss out this is SVT with Aberrancy. You really have to make some decisions in a short amount of time. And I would posit that in many cases, if you've got a rapid, wide, complex rhythm, you're probably your best bet, particularly if you're dealing with an adult patient, all right? Adult patient with a wide, complex tachycardia that's regular or pretty regular. More often than not, you're going to be dealing with ventricular tachycardia or something that is going to essentially cause the same immediate problems as ventricular tachycardia. And your best option is to proceed with a treatment pathway, assuming what you're dealing with is ventricular tachycardia, unless you have very solid reasoning against that. And I'll give a couple of examples here in a little bit. When we look at the evidence, it's pretty clear that in adults, at least, far greater than half the time, a wide complex tachycardia that looks like VTAC is VTAC. If there is any history of cardiovascular pathology, if this patient had, history of congestive heart failure, past MI, those sorts of things, any cardiovascular comorbidities, depending on the studies that you look at, you're looking at 85 to 90+% of the time that wide complex rhythm is ultimately VTAC, okay? So just 9 out of 10 times in an adult patient with any sort of cardiovascular problems, it's going to be VTAC, right? So if it looks like a duck, it walks and talks like a duck, it's probably a duck. And if they're unstable, there are any features of instability, your treatment priorities, it doesn't really matter if it's VTAC or SVT with aberrancy. Your treatment priorities are going to be the immediate termination of that rhythm in order to have a more organized rhythm, increase ventricular filling, cardiac output, myocardial perfusion. And that is generally going to be electrical therapy. It's generally going to be synchronized cardioversion, right? And that is going to get you through the vast majority of the wide complex tachycardias with features of instability that you're going to run into as an emergency and pre-hospital provider. Now, it does get inherently more complicated when your patient presents as stable, right? They have good vital signs, they have a good blood pressure, they don't have acutely altered mental status, they're not having signs and symptoms of ischemic chest pain, right? They're not having signs and symptoms of acute heart failure. They're a very stable patient, but they present with this wide complex tachycardia that may or may not be VTAC. Again, if it's an adult patient and they have any underlying cardiovascular physiology, it's more than likely VTAC. But now it's kind of like, well, now how do I address this, right? There are all these drugs, and what do I want to go with? What I would say, and I'm not giving medical advice here, these are things to think about, is sometimes not doing something is the best thing, right? If the patient's perfectly fine and stable, you don't have to do anything immediately, okay? You don't have to give a drug. You don't have to give adenosine. You don't have to give amiodarone, right? You don't have to think about beta blocker. Like you don't have to talk yourself out of like, well, this is SVT with aberrancy and I'm going to give calcium channel blocker beta. But you know what? You don't have to do anything. You get a good assessment, do a good physical exam, get a good history, right? Load the patient up, get a solid 12-lead ECG, and as long as they remain stable, you've got time to pull back, look at the bigger picture, and perhaps dial a friend, right? If you're really a lot of discussion, getting hold of medical control, not a bad idea. They may or may not be able to provide some clarity, right? Because, they may or may not agree, right? Depending on who looks at the 12-lead ECG, right? So sometimes holding off in these stable patients and just not doing anything is okay, right? Transporting, and in fact, when you look at many of the algorithms for for tachycardias in general, other than say sinus tachycardia, a lot of them will say seek expert consultation, right? And transporting that patient to definitive care where we have subspecialty resources that can look at them, and you can do electrophysiology studies, and you can do sonography, ultrasounds, and kind of really dig deep and look at these things. That's fine, right? Sometimes over intellectualizing and looking at all of these I won't say esoteric, but all these other treatment pathways while you're trying to take care of somebody in the middle of their apartment or at a grocery store or on the sidewalk, it's just it may not just be the best option, right? And so that's kind of what I'm trying to say, is that there is a big difference between the over intellectualization and analysis and discussion that we can have in a controlled didactic setting versus taking that and actually applying it in a real world, if you will, patient contact situation. And so I just wanted to make a video to kind of point that out, that sometimes stripping things down, simplifying things, and the American Heart Association, the current algorithms that address wide complex tachycardia are actually pretty reasonable. And that's just my opinion, that it's a pretty reasonable approach to addressing wide complex tachycardia. They don't even start off by saying VTAC or SVT. They just say, is this a wide complex tachycardia where the SA node is not necessarily in control of the heart? Yes or no, right? Is this a stable or unstable patient, right? Because at the end of the day, if they're unstable, the treatment pathway is actually fairly straightforward, at least the way that we immediately treat and address those dysrhythmias. Now, there are some things to think about, right? There are some caveats that you need to think about. One of the caveats, and we actually see this quite a bit, is going to be the impact of electrolyte imbalances, in particular potassium. Hyperkalemia. Hyperkalemia is not an uncommon situation, and hyperkalemia can cause wide complex rhythms, okay? So you always want to consider the possibility of hyperkalemia when you see a wide complex rhythm. Just always consider that. I mean, I know we preach H's and T's and some of the rule out diagnoses, but hyperkalemia is a big one, and it's a lot easier to miss than you'd think, right? Because it doesn't always present with the classic tall peak tented T waves, right? It may, when you get to that patient, right, they may be in that sign pattern where they have this wide, and I would say anytime you have an exceptionally wide QRS complex where you kind of look at it and your clinical gestalt is telling you, whoa, that's really wide, and it's not super rapid, right? You know, your VTAC is usually going to be, well above 100, right around 150 or so. And if you're looking at a rhythm that's, say, 110, 120, and the QRS complexes are really wide, you need to automatically be thinking about hyperkalemia and then other less common causes of these super wide, bizarre rhythms that might not be quite as fast as what you would expect with your more conventional VTAC. And in that case, you're thinking about, sodium channel blocker toxicity, TCA overdose, massive Benadryl overdose, those sorts of things. And obviously there are specific treatment pathways for those things, as well as specific treatment pathways for life-threatening hyperkalemia. So hopefully this video has provided some additional clarification on some of this, and I just kind of wanted to make a video to warn about over-intellectualizing certain concepts when you are actually encountering them in patient situations, just because I see a lot of this, and it's cool. It's actually, I really like the discussion for the sake of bouncing ideas around, but I just want to emphasize there is a really big difference between that and here we are in an actual patient encounter, and I don't have a whole hell of a lot of time to make my decision, figure out what's going on, right? And so there's a very practical component that maybe sometimes gets forgotten when we are teaching these things, and it's very, I find, and this happens to me as well, I find that when you learn something new, it's exciting and you kind of want to integrate it, and you're like, all right, I want to take this out and try it in the real world, right? And so you learn some new thing about, differentiating VT from SVT with aberrancy, and now you're like, all right, I'm going to do this on all my patients, and you spend several minutes wasting a whole bunch of time that might have been better off just spent packaging and transporting the patient, getting them where they need to go, or just addressing, hey, they're unstable. Does it really matter what we're really quote unquote dealing with? We need to cardiovert this patient, get them better stabilized, and get them delivered to appropriate definitive care. All right, so that's my video, and that's the topic I wanted to opine on today. So hopefully you all found that this video interesting and perhaps illuminating to some extent. All right, everyone, thank you so much. We'll see you in the next video.